Hello, my name is Carlos Del Rio, and I'm a professor of medicine, epidemiology, and global health at Emory University in Atlanta, Georgia, United States. And I'm here to talk to you about special populations and COVID-19. I think one issue that we have seen significantly during COVID has been health disparities. And health disparities is defined as things that affect adversely groups of people who have systematically experienced greater social or economic obstacles to health. During this presentation, I will talk to you about gender disparities in COVID outcomes. We'll talk about racial and ethnic disparities in COVID incidence and outcomes, and make a correlation with social determinants of health, and then acknowledge the role of structural racism in COVID-19 disparities and a way forward. There are several studies now that suggest that men with COVID-19 do less well than women. This is not new. There was a higher fatality rate for men, both in SARS and in MERS. There are several hypotheses for this. One of them is that estrogens are actually protective. The others suggest that there are higher concentrations of ACE2 receptors in men. And finally, there may be simply lifestyle differences, such as smoking prevalence, that may explain these differences. In this graph, we can see the disparities that we see in COVID-19 death rates comparing women in gray and men in blue. And you can see that regardless of which country we look at, the mortality for men, it's higher than for women. Let's move on now to racial and ethnic inequalities in COVID-19. It was this article last July in the New York Times that called attention to this racial inequalities in COVID in the United States. As you can see from this graph, this article documented that there were 23 cases per 10,000 population of COVID among whites. There were 38 overall, but there were 62 cases per 10,000 population among Blacks and 73 cases per 10,000 population among Hispanic Latinos. But this was not all. There was social disparities by age. And when you look at whites here in green, you can see that among whites, the increased rate of COVID did not really happen until you got to be over the age of 80. Well, you can see for Blacks and Latinos, that increased rate of COVID started happening much earlier in the late 20s for almost all populations. This disparities in race and ethnicity is also seen in hospitalizations. In this data from the CDC, you can see the age-adjusted COVID-19 associated hospitalizations by race ethnicity. And what you can see is that while for whites, there were 73 hospitalizations per 100,000 populations, for Hispanic or Latinos, for Blacks, and from Native American Indians and Alaskan Natives, there were over 300 hospitalizations per 100,000 population. Mortality has also been exceedingly high among Black people in the United States. And in fact, Black people are dying at 2.5 times the rate of white people in this country. In this infographic from CDC, the data presented as summarized. You can see that for American Indians or Alaskan Natives, for Blacks and for Latinos, the case rate is 2.5 to 3 times higher than for whites. Hospitalizations, it's almost 5 times higher, and death rates is about twice as much. So when we dig deeper into this, we found certain things. First of all, that 91% of disproportionately Black counties are located in the United States in the southern US. And in fact, only 22% of counties that are greater than 13% Black account for 52% of all national COVID cases and 58% of national COVID deaths. And underlying conditions don't fully explain these disparities. For Latinos in the US, we see a similar problem. COVID-19 diagnosed rates are greater in counties where more than 17.8% of the population is Latino. And COVID-19 deaths are greater in Midwestern Latino counties. What we find in this data is that COVID-19 diagnoses are associated with counties with greater monolingual Spanish speakers, higher heart disease deaths, and less social distancing, while COVID-19 deaths are associated with household occupancy density, elevated air pollution, and higher unemployment. But this difference between Blacks and Latinos in the US are interesting. For Blacks, for example, the COVID-19 cases are higher regardless of which kind of city we're looking at, whether you're looking at large metro cities or you're looking at smaller or non-metropolitan areas. Where for Latinos, it is more likely that you see this higher incidence and higher case rate in smaller cities and in rural communities. The increase in COVID among Latinos was clearly seen in the US after the economy opened. And it was only then when Latinos were not able to stay at home, they work in service industries and they had to go out to the community. And what we see is that after the economy opened somewhere around May, as many states started to open in the US, whether you were in the South, in the West, in the Northeast, or in the Midwestern states, we started to see an increase in the number of cases among Hispanics here in brown, regardless of where you were. And in fact, when you compare to other diseases, you realize that this is not just an HIV problem. HIV diagnosis, COVID problem. HIV diagnoses are actually higher in counties that have a higher proportion of non-white residents. So clearly, the residential segregation has a lot to do with many diseases, including COVID-19 and HIV. These findings are not just in the United States. For example, in the UK, while 14% of the UK population is a minority, 34% of COVID-19 critically ill patients are actually from racial or ethnic minorities. And in this recent study, in this recent commentary in the British Medical Journal, it shows very clearly that the COVID-19 increased risk among ethnic minorities is largely due to poverty and social disparities. This recent meta-analysis across the world, but mostly looking at the UK and the US, finds that individuals from Black and Asian ethnicities in the UK have a higher risk of COVID-19 infection compared to whites. And you can see the adjusted risk ratio for Blacks is 2.02 and for Asians is 1.5. So what are the reasons for racial and ethnic disparities in COVID? One of them, without doubt, is the disproportionate burden of comorbidities. But the fact that poor people have to live in urban settings in more crowded conditions and are more likely to be employed in public-facing occupations that prevent social distancing likely has a lot to do with this problem. Residential segregation is one of the issues that has been looked at. And it is really where you live, where you work, and how you're exposed that increases your risk. And Black and Latinos in the US tend to live in segregated and poor neighborhoods due to unfair lending practices, redlining, and blockbusting. Black and Latino neighborhoods have higher density areas that make it difficult to social distance. They also have hospitals with fewer technological resources, fewer specialists, and fewer board-certified physicians, and therefore higher risk of negligent adverse events and mortality. There's finally the epidemic of imprisonment. The risk of imprisonment is strongly related to educational attainment as well as race. And very large racial inequalities are found at every educational level in the US. There is data here, for example, from New York City. You can see here the different boroughs, the different zip codes in New York City, and you can see that zip code 11368 is one where the coronavirus prevalence was 51.6% among citizens there. And what is characteristic of that zip code? Well, it is one where the median income of residents is $30,957, which is actually the fourth smallest median earning income of any zip code in that area, in that city. In this study published recently, you can also see that the percent of households where somebody is able to not work remotely increases significantly for Latinos and for Blacks compared to whites. And therefore, it is the job you have that allows you to stay at home that actually is protecting you from getting COVID-19. But Mary Bassett probably summarizes best in this quote when she says, "The focus on comorbidities makes me angry because this really is about who still lives, who still has to leave their home to work, who has to leave in a crowded apartment, get in a crowded transportation, go to a crowded workspace. And we just haven't acknowledged that those of us who have the privilege of continuing to work from our home aren't facing those risks." Now, this is strongly correlated with social determinants of health. And you can see here on the right, poverty, unemployment, and uninsured rates. And you can see that they're much higher in the southern US, where there's a significant number of Black counties. But it's not just an HIV or a COVID-19 problem. Other conditions such as heart disease and diabetes are similarly higher in this area of the country. And we know that heart disease and diabetes are strongly correlated with a higher likelihood of dying from COVID-19. Finally, there's the issue of testing. While testing has been scaled up significantly, there's clear data in the US that testing sites are not located in Black and Latino communities where they're most needed. The impact of the economy and the economic impact of COVID-19 is more significant also among Black communities. And in fact, African Americans' unemployment has increased as much as COVID-19 deaths. So the disproportionate impact is not only of disease, but it's also of the economic loss. Now, as I said before, racial inequalities in the US are not new, and they simply have been intensified with this pandemic. And this, in fact, happened before. Here's a study published in the Annals of Internal Medicine, and we're looking at racial and ethnic disparities in the 2009 influenza pandemic. And you can see that it's basically the same. We're seeing the same racial and ethnic disparities in COVID that we saw in the flu. So what are the causes of this? Well, we know that race influences socioeconomic resources, social resources, and healthcare resources. This increases your risk of exposure and increases the risk of complications. But then racism plays in, and that leads to poor health outcomes with increased incidence of infections and increased deaths among minority populations. In summary, people of color are experiencing a disproportionate burden of COVID-19 cases and deaths. Cases and deaths are concentrated in areas with higher share of Black and Hispanic residents in the US. And disparities in COVID-19 deaths for people of color persist across age groups, and people of color experience more deaths among younger people compared to white individuals. But as I said before, it is really not race, but structural racism, which is a driving force behind COVID-19 disparities. It is the differential quality of distribution of housing, transportation, economic opportunities, education, food, air quality, and healthcare that is driving this. And the concentrated harm of the pandemic has been exacerbated by disparities in income. And therefore, policy measures to increase access to care may help to provide a foundation for health equity. But a structural component of system-level reforms are required. And in fact, we cannot treat our way out of this public health crisis without addressing social inequalities and racism. It is therefore critical that we address this as one of the things we do. And in this article, Williams and Cooper have talked about this new kind of herd immunity, how we can address COVID disparities and eliminate health disparities as a way to improve health in the entire population. But our ability to defeat COVID-19 will depend on our willingness to fight and defeat the pandemic of social determinants of health and racism that exist. Because the reality is that health equity is the road to ending COVID-19. And with that, I'll end. I will to acknowledge Julius Weidler, Gregory Millet, and Wendy Armstrong for providing me slides and information for this talk. Thank you very much.